I'll be talking about novel imaging for renal masses. I have no disclosures, and we certainly have some serious gaps in knowledge. Dr. Landman showed that 4+ centimeter renal mass, and really when we see it in the office, we don't know if this is going to be, little benign Arya Stark when she was a little kid, if anyone watches Game of Thrones, or if she's going to be badass Arya, and if anybody hasn't seen the last episodes, maybe ignore this slide. But the reality is, when we see the tumor, we don't know if it's a pussycat or a tiger, and there is some value in knowing this, whether it's to understand when to operate and when not to operate. But I would also argue that when you operate, how you operate may be affected by knowing something about the biology of the tumor. So even if you were to remove an oncocytoma, if it's a difficult partial embedded in the middle of the kidney, you may feel better about hugging the tumor if you knew that it was more likely to be an oncocytoma or an indolent lesion versus a more aggressive renal cell carcinoma. Why is this important to us? Well, as robotic surgeons, and I think this is a luxury for us, and it speaks to the achievement levels of robotic surgeons everywhere, is we have become the stewards of really small renal mass or kidney cancer management, because this is the most common modality of treatment. We also work with technology that has the promise to unlock biological information in real time. ICG is an example of that. There's this phenomenon of autofluorescence. Dr. Hemal published papers on this. But we also have new augmented reality emerging technologies. And imagine a reality where you could inject various tracers that can bind to the tumor and tell us something about their biology, and in real time, using near-infrared imaging, be able to tell what we're dealing with, and maybe even avoiding the biopsy step if surgery is in the future, no matter what. We know that we remove a large number or a significant proportion of benign lesions, and some are probably for good reason, but others probably avoidable and probably not a good idea. We also know that the diagnostic accuracy of biopsy, while much better today than it had been in the future, is not perfect, and we still have a non-diagnostic rate of 14%, and I think in Dr. Landman's hidden in his table was a greater than 20% non-diagnostic rate. So even if we were to biopsy, we would be headed into the OR with uncertain information in some patients, and maybe intraoperatively with emerging technologies and some of the science behind what I'm going to talk about, we could do a lot better. I would argue that today radiographic biopsy is already possible, and I'll show you some data on just conventional CT scan, a scan called a Sestamibi scan that's used for parathyroid and heart imaging that we've now kind of changed purpose and have purpose-built it for kidney tumor imaging, CA9 imaging, and then PSMA PET, which we all know for prostate maybe, also has applications in kidney cancer. So we'll start with a case of a 79-year-old male who has an estimated GFR of 45, presents with a 9-centimeter incidental renal mass. So this is not the small renal mass, but just to emphasize utility of these technologies. Has a mitral valve replacement, so really needs to be on anticoagulation, and has this lobulated, avidly enhancing renal mass with a central hypodensity that is could be necrosis or could be scar. And at Hopkins today, this patient would automatically get a Sestamibi SPECT CT scan. We incorporated in our medical record, so this is on Epic, we can order it, and we obtained a Sestamibi scan on this patient, and you could see the tumor lights up with the radio tracer, so it is Sestamibi hot, and we know based on our science that I'm going to show you that this is an oncocytoma, or most likely an oncocytoma, and he's now 4 years out from initially seeing me, having had 3 other urologists recommend a radical nephrectomy because this is a monster tumor, and is still active and engulfing. To show you that this is not a one-off, here's examples of 3 oncocytomas of different appearances. This is the more classic CT scan, right? The central scar, the spoke wheel scar, if you will, and it's hot on the Sestamibi, and it turns out to be an oncocytoma. This is more of a subtle, maybe central scar, also an oncocytoma, and this is yet another look at it. And I think, one can make an argument that all 3 look like a renal cell carcinoma. Here are some resected renal cell carcinomas, an infiltrative, ugly-looking thing, cold on Sestamibi. Same thing with this one and that one, and these are a variety of histologies. So clear cell, unclassified, translocation, papillary, we've had experience in. And the reason this technology works is Sestamibi scan lights up when it's a imaging test for oncocytoma, for mitochondrial content. And oncocytomas under the electron microscope are chock full of mitochondria. In distinction, clear cell renal carcinoma is actually relatively devoid from mitochondrial content. And another reason, so the Sestamibi is a cation, it gets into the cell and binds to mitochondria, but also kidney cancer has the MDR, or the multi-drug resistant pump, which is why it's resistant to chemotherapy, and that turns out that it also pumps Sestamibi out of the cell. So a cancer is more likely to not pick up the Sestamibi, and an oncocytoma is more likely to pick up the Sestamibi. And here's some immunohistochemistry showing mitochondrial markers that are not picked up by papillary RCC, but picked up by oncocytoma, and MDR, which is picked up by cancer, but not in oncocytoma, telling us that that mechanism of action is likely the correct mechanism of action. And this work has been already published in our literature. We ran a prospective trial published in European Urology, and it showed this data. And if you look at this table in particular, we basically missed 2 renal cell carcinomas, and those turned out to be chromophobe RCCs. So we believe that if it's a small tumor and it's hot, it's either an oncocytoma, or if we miss anything, it's going to be a chromophobe, and we believe that these small chromophobe RCCs are likely indolent, and if you're thinking about observation or an aggressive surgical resection, a tight enucleation, that maybe that would be valid for those tumors. And these are the sensitivity and specificity in our first trial. This has been now replicated in Sweden through the MIDOR trial and published, and you could see the specificity and sensitivity hold. We've now imaged over 100 patients at Hopkins, and if we add the data from the published external validation, we still come up with great sensitivity and specificity, so great performance characteristics for the scan. The other thing I would remind everyone is that you could use this data and then go to your CT scan, and we know that clear cell carcinomas enhance avidly with contrast, and so do oncocytomas. Papillaries are hypoenhancing, and then chromophobes tend to be the more challenging variables. So if you have an avidly enhancing mass that's hot on Sestamibi, that's going to be an oncocytoma. So it gives you secondary confirmation, because now you have a CT showing great enhancement and the Sestamibi scan, whereas if it's cold on Sestamibi but enhances on CT, more likely a clear cell RCC, and if it hypoenhances on the CT plus cold Sestamibi, it's more likely to be a papillary. So you already can kind of come up with some histology there. This is CA9. In this report, it's an antibody highly bound to clear cell RCC. This is a JCO paper published a while ago. The company that makes this went out of business. They've now resurrected and are going to run a second trial. But this would be a marker for renal cell carcinoma, and it's also using similar nuclear medicine technology. And we at Hopkins have come up with a small molecule. So there's a subtle difference between the antibody, which was the prior trial, and these small molecules. So this would be like the PSMA PET type of imaging, and we're working on a dual tracer, so we could do Sestamibi CA9 together and maybe marry them to a tracer you could use in the OR that you can then turn near-infrared technology and be able to tell histology in real time. I'll quickly go through the next case of a 73-year-old who also has chronic kidney disease, a solitary kidney from a nephrectomy for RCC 10 years prior, and presents with a challenging renal mass and also a adrenal lesion that is indeterminate on imaging. And the question is this kidney tumor a cancer? Is it a metastasis? And so PSMA actually is heavily expressed in the neovasculature of renal cell carcinoma. So it's a misnomer that's prostate-specific membrane antigen, and we have a PSMA PET scan that we can use to potentially image these lesions. And we did a variety of studies using conventional imaging and PSMA PET, and we found that with PSMA PET, you pick up all sorts of metastasis that you don't pick up on CT and bone scan, and we even went far enough to do a rapid autopsy on a patient who expired, who had been imaged with CT, bone scan, conventional PET, and PSMA PET, and we found weird sites of metastasis in the tricep, in the internal mammary chain, and we confirmed them on autopsy to be renal cell carcinoma. So we think we have a very good imaging agent in PSMA PET to stage renal cell carcinoma. So these are internal mammary gland, and furthermore, there was an inguinal node that was picked up on a CT scan that was cold on the PSMA PET. So you would have thought that was a metastasis, but the PSMA told us it wasn't, and indeed it was a necrotic node that had been treated by treatment. So to make a long story short, the patient had a PSMA PET, and it was positive on the PSMA PET for the adrenal gland, and that was resected and found to be clear cell, and the Sestamibi was cold for the renal tumor, also indicating that it was a clear cell, and we were able to resect it, and we were doing a study with OCT to look at margins, so even though it looks enucleated here, you could see the pseudocapsule beautifully on a more sophisticated imaging. And so at the end of the day, I think that information the patient appreciated going to the OR for a slightly high-risk operation, knowing that they needed the surgery and knowing what the issues were. So in conclusion, Sestamibi and CA9-based imaging are promising imaging modalities for renal tumors, and I think the future will be near-infrared imaging coupled with the scientific basis of this stuff. Maybe Sestamibi is green, CA9 is red, and you're doing somebody with multiple renal tumors that, and you go around and you could kind of figure out the biology of them, and we could start to make decision-making on margin length and aggressiveness in the surgery, or maybe leave some tumors behind as robotic technology progresses into the next, because I think it's an enabling technology that has to progress from where we are today. So I don't think we need to biopsy the majority of tumors because radiographic biopsy is here, but I love the fact that we have now better biopsies and better imaging, and all of this is going to help our patients. And thank you so much for your attention.